Good afternoon, everyone. Scrolling through, seeing how many people we have before we decide to get started today. A good number of people. Thank you so much for joining us today. I know people will continue to join. My name is Olivia Alford. I'm the Deputy Director of Policy and Programs for the Office of Main Care Services. We are very glad you've joined us. We are super excited to provide you with this update today on where we are at Main Care with thinking about our primary care payment reform efforts. So you may know, as a provider, as another payer, as a member of the general public, that primary care is critical to our healthcare infrastructure, to how we all access and receive high quality services, and how we control costs within the Maine Care program, and for all of us as people in Maine. We've been working over several years to think about how to best support primary care providers in doing what they would share with us as goals to provide high quality care to Maine residents, and specifically here talking about Maine Care members. We've been working over the years to think about the ways that we can change the way that Maine Care pays for services and delivers and has policies that articulate how primary care providers can take advantage of alternative payment models to improve the care that they deliver. So this is not a new project. It's something we've been working on for several years, but what we're hearing from today is an update on how we've been working with our partner, Manat Health, over the last several years, year and a half perhaps, at redesigning what we call our Primary Care Plus program, which is our main primary care program for Maine Care. We're going to spend some time today going through some high-level articulation of goals of this work, where we are in this process, and then getting into some pretty detailed slides about what we're thinking in terms of payment methodology, alternative payment models. We wanted to have this conversation now as we are wrapping up this initial phase of what we call service model design, like really thinking about how do we move this work forward for the Maine Care program. We will have plenty of opportunity today to accept questions via the question and answer module or link in your Zoom. We are going to also try to save time at the end of this conversation with Manat to answer live questions. If you are having any trouble finding your Q&A button, there's a slide up showing you how to find it. But if you don't see it initially, go to that triple dot ellipse at the bottom of your Zoom screen to get additional options, and you should be able to select the Q&A box to have it appear for you. So Maine Care staff are on here, other department staff. We are all, have been working on this behind the scenes, but you are primarily going to hear from Manat Health today to lead this conversation, and they've done a great job working with us on these changes. Let's see. These slides and a recording of this meeting will be shared afterwards on the Maine Care Rate Reform System page, which is here. Also sent out via an e-message. And they also have this email box where you can send any questions that you feel like you thought of after the meeting or didn't get answered today. So we will hand it over to Manat again to speak through this presentation. Please do, though, during the presentation, put your questions into the question and answer box, and we will answer them live via the chat. Or we may say that some questions we're going to want to have a conversation about, and we'll do that verbally during the call. So again, very excited that we've reached this point to provide this update for you. People are still joining. They haven't missed anything. We're just kind of killing a few minutes of time before we get started. But I won't do that for any longer, and I'll turn it over to Avi from Manat. Thank you.
Great. Thanks so much, Olivia. Really appreciate it. Hi, everyone. Good afternoon. My name is Avi Herring. I'm a managing director with Manat, and I've really had the privilege to work with the department on thinking through the next phase of PCPlus. Again, we've been doing this work over the last year and a half or so and are excited to be sharing a status update on where we are. So let me just quickly walk through our objectives today. The first is really to introduce the key components of the future state of PCPlus, and to really help explain how this future state will differ from the kind of current structure of the program. The second piece that's really important, and we, as Olivia said, we encourage questions and comments throughout using the Q&A function, is to really continue to gather feedback from stakeholders on the department's thinking around program design. And then to talk, excuse me, to talk through next steps on the continued development of this future state PCPlus model, and also identify future opportunities for stakeholder input. So that is the plan for today, and we're going to jump in. Let's go to the next slide, please. Okay. So we first just wanted to give folks a bit of an update on the work we've been doing over the last number of months, kind of where we are now, and then where the department anticipates moving in the next few months. So just looking back from January to August of 2025, we really were focused on objectives, focusing on determining the aims for the future state of PC+, digging into the data using historical claims data and spending data to really be able to evaluate sort of the current state of the program. And we also did conduct some initial public stakeholder meetings last August as well. Between September and really 2025 and now in March 2026, we've been focused on the design process and the design sort of section of this work, where we've been looking at primary care models and best practices in other states, developing a whole series of options for future state design, which much of which you're going to hear about today, around the kind of first of all overall framework for how the model will be structured going forward, the care delivery requirements, high-level payment methodology, and the approach to health-related social needs risk adjustment and integration of community health workers. There's also been significant work to engage FQHCs and community health worker advisory groups on the design. And then obviously today, we have our public meeting to present the kind of initial program design. Again, this is the sort of initial straw model construct to share for stakeholder feedback. Between April of 2026 and then December of 2027, there will be opportunities to solicit and integrate stakeholder feedback, including what we hear today, to finalize the PC+ design, to really dig in on the rate methodology and the rate setting, right? What we're going to walk through today are the sort of design framework and the high-level payment methodology, but there will be additional work on rate methodology development and rate setting. And then it'll really move towards preparing for implementation. The goal is, for the launch of the future state program is the middle of 2028, but that is tentative and subject to change. All right, let's keep going. So let me just explain a bit what we're going to walk through today in the next bit of time that we have together. First of all, we're going to talk about the kind of broader and overall structure, goals, and participation criteria for the PC+ future state. That's going to be the kind of overall framework. Then we're going to move to talk through updates on care delivery requirements, integrating community health workers, the member attribution methodology, the payment framework, and then a whole set of potential adjustments to payments under the PC+ future state model. So just a bit to do in the next hour and a half that we have together. All right, let's move to the next slide. Okay. So let's just first, before we really move into the explaining the overall framework for this next phase, we just want to do a little bit of level setting about payment terms before we go any further. So let's just first talk about for a moment the difference between fee-for-service payments, and capitated payments, right? So at a high level, healthcare providers can be paid in a couple of different ways. And two of the very common models are fee-for-service payments and capitated payments. In a fee-for-service construct, in this case, MaineCare, right, makes a payment, right, or OMS makes a payment to providers for each service provided, right? So that means that each visit, test, procedure is billed separately, and there is a volume incentive, right? As payment increases, more services are provided. Capitation, a capitated payment, or what we're also going to refer to as a PMPM, or a per member per month payment, that is a fixed payment that covers a defined set of services. And just for reference to the current PCPlus program, the population-based payment is a capitated payment currently. That kind of payment is based on the defined population that is attributed to a practice, and it is not based on the number of services that are delivered. And then what ends up happening is the practice then sort of manages the member's care within the fixed budget that it receives for the attributed patient. What you see on the right here, right, when we talk about alternative payment models, right, when moving away from fee-for-service and especially towards capitation, that's often sort of referred to as an alternative payment model. And what we're saying here, and what's really important, is that as we move forward, the transition to capitation paired with a set of quality benchmarks, and we're going to talk a bit more about that today, will really represent a transformation in how PCPlus practices are paid. And the goal here is that the program will support participating practices to act as a member's primary care medical home, to coordinate whole person care, to prioritize engagement, coordination, and prevention services. And we're going to talk more about that in terms of the broader set of objectives and then how this initial thinking around the changes to the design really are intended to support those goals. Okay, let's go to the next slide. So to talk for a minute about the future state of PCPlus, we really want to start, and it's always important to ground these discussions in objectives, right? So when we think about the current aims of the program, you can see those on the left here. And then on the right, you see both future state aims of the program, and I'm going to explain how those differ, and also future state guiding principles that are new and are something that we're now really thinking about as underlying the program design for PCPlus and other types of alternative payment models that the department and that OMS is driving forward. So when we think about the aims here and the difference between the current and the future state, we're first of all carrying forward the aim that's focused on improving health and health outcomes, right? That remains the same from the current to the future state. We've also added a new aim that's focused on access to primary care services, again, in a way that was not as explicit in the current aims. In the third aim here, you'll see the language is focused on delivering whole person primary care that is responsive to members' needs. That is, again, we're continuing on that focus on whole person care, but also we're making sure that we're adding that sort of angle around primary care that is responsive to members' needs, that is really member-centered. And then finally, the last goal here is around supporting practice transformation through alternative payment models, and that is very similar to the current aim. We've just changed the language a bit. You'll then see at the bottom that these guiding principles are new, that we're sort of initially proposing here to include in the future state. The first is focusing on promoting multi-payer alignment, and that also includes alignment with other alternative payment models that exist in the state, right? So for example, the Accountable Communities Program, fostering partnerships across the healthcare delivery system, ensuring that stakeholders are engaged in program design and implementation. And that's, again, as you saw, as I explained a few minutes ago, that's of course the purpose of this call and this discussion, but will also be lots of additional opportunities for stakeholder feedback. A significant and important goal in the future state model is to try and minimize administrative burden for both providers and for the state, right? We want these programs to work well, to incentivize the delivery of the right kind of care, but to do so in a way that is efficient and is mindful of the administrative burden that is placed on both providers participating in the program and on the department in terms of its kind of oversight and administrative role. And then, of course, and this is what the department and what OMS really does throughout its work, and that we've been able to partner with OMS in focusing on how we're leveraging best practices and learning from other states. Right, we're not reinventing the wheel, and it's really important to learn from how other states have implemented these kinds of models. So that's just the kind of high-level overview around current versus future state aims. Let's go to the next slide. Okay. So this is a really key point that we want to make here, and then we're going to make it in a number of different places as we go into further detail. So the way that the PCPlus model is currently set up is that there are different tiers, right? Tiers 1, 2, and 3. Those differ by care delivery requirements. And as you go up, from one tier to the next, there are a greater level of care delivery requirements. Those drive higher population-based payments. And there really is a kind of fluidity around participating providers moving across tiers. In the future state, the thinking here is that we would move from these different tiers to really different models that are designed for different types of providers with very different types of payment structures. And what we're going to walk through today is a future state with 3 different models that are available to different types of primary care practices with differing payment model types. So model 1 would be for a subset of primary care practices that do not meet what we're calling, I'll come back to this in a minute, do not meet what we're calling advanced APM readiness requirements, right? So alternative payment model readiness requirements. Model 2 would be for primary care practices that do meet those requirements, but are not FQHCs or RHCs. And then model 3 would be specifically for FQHCs and RHCs. A key point here is that models 2 and 3 will newly incorporated capitated payments for medical services, which is not something that is included in the current PCPlus model. And that is going to be really a significant change in the future state framework here. The one other thing I'll just note as we're thinking about model 1, and when I noted that for the subset of primary care practices that don't meet these advanced APM readiness requirements, Olivia will share more about this later. But just to note that OMS will be conducting an APM readiness assessment as part of implementing its rural health transformation program. And that assessment will also be used to identify eligibility for these PCPlus future state models. That assessment is still in its initial phases and it's under development, but we expect that it's going to include a focus on, for example, data infrastructure and population health management capabilities, financial capacity, and practice ownership and affiliation status. So, for example, whether the practice is owned by a hospital system or is a provider-based site of a hospital system. So again, more to come here, but there will be more information on how that APM readiness assessment will be administered in the future. Okay, let's go to the next slide. Okay, so as we think now, really and zoom out and think through the whole set of PCPlus program components. we want to just lay out for folks on the call here what is changing in the future state at a very high level. And then I'm going to turn it over to my colleague Emily Polk in a minute to walk through in more detail what some of these changes will look like. So as we just kind of go component by component here, for care delivery requirements, OMS is working on a refined set of requirements. Those will vary by model. We're going to share some initial thinking on the care delivery requirements today, but there will be more design work happening on that in the future. Moving on to CHW requirements, here OMS is considering new policies to further advance CHW integration into the PCPlus care delivery model. The member attribution methodology, which is a core component of really any type of alternative payment model, but in particular the PCPlus model, right, where capitated payments will be driven by member attribution. That methodology will largely align with the current state, but there will be some updates that we'll talk through. Then moving on here to medical services payment type. And I just noted this before, and I want to note it again, that there would be a transition in models 2 and 3 to capitation, right, to these per member per month payments for medical services. And again, in a bit, we're going to walk through more around how that would work. Moving to the population-based payment, the PBP, this will be recalculated in the future state, right? The PBP is for care coordination, outreach, and engagement, and the rates will differ from the current state. That will happen in a subsequent phase of work. There will also be adjustments for health-related social needs in ways that the kind of current PBP does not account for. And then on the performance-based adjustment, right? So how will rates and payment levels be adjusted for quality performance? That is still an area that is to be determined, and there will be additional work on that in a subsequent phase. So that is the kind of overall update at, really at 30,000 feet. As you're kind of digesting all of this, and I know that this is a lot to walk through, please, put questions in the Q&A, and we'll definitely address them as we move forward. With that, I want to turn it over to my colleague, Emily Polk, who has been helping drive much of the design work along with myself and with the OMS team over the last number of months. And Emily, please take it away to walk through more of the details.
Thanks, Avi. And hi, everyone. As Avi said, my name is Emily Polk. I'm a senior manager with Manat and have been working with the OMS team on this PCPlus program. And I'm excited to walk through some of the nitty-gritty of the program design updates going forward. So starting with care delivery requirements, let's start by defining what we are talking about when we say care delivery requirements. These are mandatory standards, policies, protocols that practices need to meet to participate in the program. As we talked about in the current state, there's different tiers with different care delivery requirements that providers need to meet to be able to participate in those tiers. The requirements listed here are just examples to give an illustration of what we're talking about, because care delivery requirements can be really about care delivery, so providing 24/7 coverage, for example, but they can also be about IT and data infrastructure, about governance. I think really importantly, they can focus on population health and social care, so advancing those whole person care aims that we talked about around offering CHW services or conducting health-related social needs assessments. So they really span a wide variety of topics, and at the end of the day are seeking to tie many of the aims around what we want the care delivery model to look like with the requirements for participating in the program. So these are part of the model now and will continue to be part of PCPlus going forward. So OMS is currently in the process of updating the care delivery requirements, the current care delivery requirements for this future state. and that is still under development, so we don't have a set to share with you today. But in terms of process and what OMS is thinking about, we're starting with reviewing the existing requirements and thinking through, what's working, what isn't, what are other states doing in this area, and to what extent are the existing requirements furthering our aims for the program, and thinking about, which ones are we going to carry forward into the next phase of the program. We're then thinking through what else is needed. So we introduced a new aim around improving access. So that's a key area that we're thinking about in terms of what requirements do we want to be part of the program that would seek to improve access to care. Same day access, extended hours, things like that. So that's one key area that we're thinking about for kind of an expanded set of requirements. We're also thinking through how can we make sure that our requirements are promoting this whole person care vision? So what are potential expectations around outreach, engagement, care coordination, these kinds of services that might not be our usual medically billable services, but are really important to making sure that we're meeting patients where they are and are providing that whole person care. So an example there would be same day coordination with a CHW, again, deepening that requirement around how we're engaging with patients. Again, these are still areas for exploration, and in a future presentation, we'll share more in terms of what these requirements will be for feedback, but want to provide an update that these are some key areas that we're thinking pretty hard about. So more to come there. I will keep us moving to talking about CHWs specifically. I know we've mentioned CHWs being an important part of the program already, and want to start by level setting. I think folks on this call are likely largely familiar with CHWs, but want to make sure we're all talking about the same thing here. Again, CHWs are incredibly central to providing whole person care to main care members. And we're referring to CHWs as individuals that support main care members, not only in navigating health and healthcare, but also in accessing community resources, social services, health education, and broadly helping people kind of remove barriers in their lives to achieving good health. CHWs oftentimes come from the communities they serve, and in that way are really strong at building trust, meeting people where they are, and have become a really important part of primary care teams as well. When we think about CHWs in the PCPlus context, the current program has a care delivery requirement for tiers 2 and 3 specifically, that practices must engage with CHWs in one of two ways. So one, practices can employ a CHW directly. So that's the model shown on the left here, where the practice, again, employs a CHW. That CHW works directly with the care team and helps members navigate healthcare, navigate social issues, really kind of spans that set of services we talked about on the last slide. Separately, practices can contract with community-based organizations on the right of this slide in blue to provide CHW services. So we oftentimes call those community-based CHWs or CBO CHWs to layer more acronyms on. But these are essentially CHWs that are oftentimes more located in the communities they're serving as opposed to at the practice. And in that way, they're providing kind of community support in those community settings. And oftentimes they're working with multiple PCPlus practices. A key difference here, both are helping members navigate both health and social needs. The directly employed CHWs are more likely to be closely linked to the healthcare system and the healthcare that someone's receiving, whereas this community-based CHWs are more closely linked to the community and community resources, although they're both working across both. So that's in the current state, practices can do either of these options. It's much more common for practices to be employ CHWs. And we'll talk about that a little bit more as we go forward. So in thinking about further integrating CHWs into the PCPlus program, the OMS team started with thinking through what are our aims? What are we trying to do? So we talked about broad program aims, and these are really our aims specific to CHWs in the program, so a narrower set. And OMS laid out 4 key aims regarding CHWs that we're trying to advance through this future state of the program. The first being promoting the use of these community-based CHWs to better engage members and address health-related social needs. It's fairly uncommon at this point for practices to be working with these CBO-based CHWs, and OMS is seeking to promote that, again, to promote models where CHWs are really based in their communities. The second aim here is around improving integration between CHWs and their care teams. So making sure that CHWs are really involved and providing services to patients. The third here is around minimizing administrative burden. That's a key theme that we've been thinking throughout this process, wanting to make sure that whatever policy changes we're putting into place are as streamlined as possible, because we know that these models can become complex quickly, and we want to make sure that we are minimizing that to the extent possible while also trying to achieve our aims. And then lastly, making sure that in the future state, these care delivery goals for CHWs are aligned with how practices are paid. So making sure that payment kind of follows these goals and incentivizes these goals is, of course, a key component of this going forward. Okay. So I'll say for the next phase of the program, there's a few things that we've kind of decided and have kind of future state policy on, and a few things that are still underway and under development. The first thing here is that OMS plans to retain the requirement that practices can either directly employ CHWs or they can contract with CBOs that have CHWs. This is recognizing that practices have invested in this. This is the current requirement for 2 of our tiers, and consistency here will be important to allowing practices to continue what they've already invested in, and also both of these types of CHWs are important and valuable to the program. The second section here on the slide shows a few policies that OMS is considering to further advance the department's aims with respect to CHWs. And I'll say before we get into these are options that are under consideration. These are not a final policy set. And so we really are excited to hear thinking and feedback around these options as well. The first on the list is to set a minimum standard in terms of the hours, the CHW hours provided by each practice to its patients. So a number of hours per attributed patient, for example. We understand that the amount of CHW services actually provided to patients really varies in the program in the current state. And so in this option, there would be basically a minimum standard there, a floor, where of course more services are always welcome, but it would basically bring everyone to the same place in terms of the number of hours per patient that are being provided. There's more work to be done here in terms of figuring out what that would look like. What would the hours requirement be? And that would be something that would be done in consultation with practices, just to make sure we're not trying to kind of pull a number out of the air here. but that is one option under consideration. The second here is a payment increase for practices that contract with CBOs for CHW services. Again, in alignment with that aim to promote use of CBO-based CHWs. This would also reflect the fact that it can be more costly to contract with a CBO to provide these services rather than directly employing a CHW. And so incorporating a payment increase for these practices also not only incentivizes the activity, but recognizes the fact that it can be more costly to do that. The third option here is around strengthening care delivery requirements for services often supported by CHWs. So rather than just saying practices need to contract with a CHW or employ a CHW, requirements around the specific services that need to be offered. Again, that could include same-day access to CHWs, as was mentioned earlier, or a number of other specific service delivery requirements. Again, these are options for consideration, and we'd love thinking around any of them in terms of feedback. All right, I will keep us moving to attribution. So when we talk about care delivery requirements and CHWs, we're really thinking about, what kind of care, what's the service delivery model that we're envisioning for this program. This next section on attribution, and then we'll get to payment, is a little bit more about the nuts and bolts of how this would come together and work and how payment would flow. Starting with defining what are we talking about with attribution. Attribution is the process for determining which panel of patients a PCPlus practice is responsible for. And that is not to say they are the only patients that a practice serves, but they're the patients that will be incorporated into one, determining PCPlus payments. So when we say per member per month, those are the members and the per member per month. And they're also the members that we're looking at when we're figuring out what should the per member per month rate be. So we'll look at historical utilization of these patients to figure out what should rates look like. They are also key to quality measurement. So attributed patients are those that will be looked at when a practice is evaluated based on performance. So the payment component and the quality component are the two really big pieces that attribution drives. As I said, this is not to say that PCPlus practices will only be paid for these patients. Other patients who are not attributed to a PCPlus practice can visit a PCPlus practice and still be paid for. Practices will receive fee for service or encounter rate if they're FQHCs, reimbursement for patients who are kind of outside of the attributed population. So just want to be really clear on that. The next slide goes into what we're thinking about attribution for the next phase of the program. So as Avi stated at the top, the future state attribution methodology will look similar to the current state attribution methodology with some changes to improve upon it and reflecting the feedback that we've gotten so far on the existing methodology and to align it with the future program design. So we can take this piece by piece. The first thing here is that attribution will prioritize if a member has a stated preference. This is generally, I think, less common, but when a member says, XYZ provider is my provider, that will be considered in determining where they are attributed. That's current state, that's also future state. The second row here is arguably the most important row in terms of determining attribution, which is in the current state, attribution is based on which practice provides the most primary care services to a patient in a certain historical window. And that will be the future state as well, where primary care utilization basically determines where somebody gets attributed. The key thing here for the future state is that we will be reviewing and updating the list of codes. So, for example, procedure codes that determine what claim counts as a primary care claim. So that is to be adjusted and to be updated in the future state. But the core premise here that we will attribute people based on their primary care utilization will stay the same. The third row here is something new. OMS throughout this model is promoting the provision of these non-billable, non-kind of primary care services, such as care coordination, outreach, engagement services, and recognizes that these are really important touch points with patients that aren't necessarily captured when you just look at primary care claims. What OMS is considering are options to incorporate these kinds of touch points. So, for example, a visit with a CHW into the attribution process. Now, I want to be clear, this would not mean that just working with a CHW would be the only thing that would attribute somebody to a practice. This would only apply to keeping somebody attributed at their practice. So, for example, like if an individual has a primary care provider and is attributed to them in PCPlus and goes a span without a primary care visit, but then they're engaging with a CHW at the practice to navigate care, for any of the kind of services that CHWs provide. OMS could count those touch points towards keeping that person attributed at that provider for a time. There's plenty of details to work out here, but want to just highlight that this is something that we're thinking actively about for the future state of the program. The last two rows here are more nuts and bolts on how this would come together. First, the look back window for figuring out which practice provided the most primary care services. Right now, that's 24 months. In the future state, OMS plans to shorten that to 18 months to align with more recent utilization, but also to align with the AC program. This is a good opportunity for multi-payer alignment. And the last row here basically states the current program does this reattribution, so goes through this process of figuring out what patients are attributed to a practice quarterly, and so that would continue in this future state of the program where this process happens on a quarterly basis. So that is attribution, current and future state. Again, it's more tweaks around the edges to improve what we already have. And I'll also just add this process will attribute folks to all three of the models we've talked about. Okay. So attribution is one thing. Payment model is, I'm sure, what folks are excited to hear more about. And we've talked a decent amount about kind of moving towards capitation. And so in this section, we'll talk about what are the key components to each practice's payment, how might they be adjusted, and how does that all differ by model? So we will start with the components, the high-level components of payment. And this is not to say that these will look all the same across models. This is just defining what are the building blocks, and then we'll go model by model and talk about how they differ. So first on the left in yellow, you'll see the medical services payment. So this is the payment for clinical services that a practice receives. So that can be either fee for service, which is the current state, or a PMPM or capitation, as we've talked about. When we say the population-based payment, that is the payment for care management, outreach, engagement services, the set of care delivery requirements that go beyond medical care reimbursement. And that has been and will continue to be a PMPM payment. Then there's the purple performance-based adjustment. So the payment associated with provider performance, and the design of that is, again, still underway. So when you combine all these pieces, you get a practice's total primary care payment. Before we get into how they all differ by model, we also want to do some defining of the adjustments that go into each of these components. Again, these will differ by model, but want to make sure that we're speaking the same language when we're talking about adjustments. So the medical service payment can be adjusted for two things. The first is leakage. So if a patient is attributed to one provider and then visits another provider, we basically need to make sure that the PMPM that their attributed provider gets accounts for that and only pays the provider for the care that they provide as opposed to the care that another provider might provide to that patient. And so that's what we're talking about when we say a leakage adjustment. Separately, the medical services payment can also be adjusted for medical risk. So I think this is a more standard or well-known type of adjustment. If a practice sees a higher complexity set of patients or higher medical risk patients, that can be reflected as an adjustment in their payment level to make sure that payments are kind of accurate and fair. Moving on to the population-based payment. So the population-based payment can be adjusted, and frankly, in all of the models, is adjusted for health-related social needs. So this is a really key new component of PCPlus in the future state, where payments are adjusted to account for differences in these health-related social needs. So housing instability, food insecurity, things like that. And we'll go into more detail on what that might look like. Then lastly, on performance-based adjustments, I think this section or these payments might be structured as an adjustment to one of the prior two, or might be its own payment, which is why we kind of separated it out here. But just want to say that design is to be determined, and how that fits into the other payments will be a subject of future communication. And we're thinking through options as to how this could look going forward. Okay. So diving in to health-related social needs adjustments, since this is such a new and core part of PCPlus going forward, want to make sure that we're kind of level set on what we're talking about. So again, an HRSN, a health-related social needs risk adjustment, is an adjustment to provider payments based on these health-related social needs listed on the left, and potentially others. Basically factors that might increase the kind of cost and resources needed to care for a set of patients. The goal of doing this HRSN risk adjustment is to really reflect the increased resources that are required to care for members with significant health-related social needs. And so in one way that increases payment accuracy and better reflects care needs, while also being a tool to incentivize providing care to these populations, and to promoting the whole person care we've been talking about throughout this model. So that's what we're trying to do with health-related social needs risk adjustment. The question is, how will we do it? In terms of defining and measuring health-related social needs, that is still underway. The thinking here is that OMS will use member-level health-related social needs data to do this. And this can look like a few different things. It could include provider-collected data, for example, through screenings. It can include other administrative data, such as from eligibility systems. And we recognize that if OMS is to use provider reported data, just want to be super clear that we understand that this would be a lift for providers, and OMS is committed to working with practices to figure out how this could work in a way that would be as seamless as possible, and to troubleshoot any issues that may arise. So just want to say that up front. We know this is an area that will take further work. So once we measure HRSN and figure out what a population's health-related social needs look like, and we said this in a prior slide, but want to just make sure it's clear, the population-based payment will then be adjusted based on a practice's attributed patient population's HRSN risk. The other kind of caveat we wanted to highlight is that HRSN risk can vary across population groups. For example, it may be higher among adult populations compared to pediatric populations. And so OMS is thinking through, are there other population group adjustments we might want to layer on top of HRSN risk adjustments to make sure that the health-related social needs adjustments feel fair, and aren't creating any kind of unintended consequences. So that is being thought through going forward. All right. So now we've talked about the building blocks, and this slide seeks to summarize how each of those building blocks is evolving from the current state to the future state. And so we can take these one by one. The first is the medical services payment. As folks have heard so far, in the current state, practices are paid fee for service for medical services. And in the future state, this will look different by model. So you'll see three different kind of answers to this question here on the slide. So in model 1, which is for, again, a subset of providers that do not meet higher level APM readiness requirements, those providers in model 1 would continue to receive fee for service for medical services payments. Models 2 and 3, however, would shift towards a PMPM capitation for medical services. Model 2, again, which is for primary care practices that are not FQHCs and RHCs, would receive this PMPM to cover basically primary care and then primary care services, and then behavioral health services offered in a primary care setting. Model 3 would get a PMPM that would actually be broader for a set of integrated services that FQHCs and RHCs are providing. So that's a key difference there. We've already talked about population-based payments, but just to say, the current PMPM will be updated, so will be newly calculated in the future state compared to the current state, and the risk adjustment process will change. Right now, the current state has the population and risk and medical risk adjustment to the population-based payment, and in the future state, that will be an HRSN-focused risk adjustment. For the performance-based adjustment, that right now is a kind of plus or minus to the population-based payment based on performance, an increase or a decrease. And again, in the future state, that structure will either continue or be altered, and that is to be determined. I'll just add, I think we talked at the top about capitation being a vehicle for promoting whole person care. And I'll just add that the goal of these various components, the capitation, the HRSN risk adjustment, the population-based payment, all of those are really centered around providing that whole person care, about meeting people where they are and kind of acting as a medical home for a patient and paying providers in a way that reflects that. I'll also add that the different models here are really seeking to promote the practice transformation we're talking about by one, having different models for different provider types, so that we can really meet providers where they are, depending on kind of how APM ready they are. And then lastly, want to make sure it's clear, while the performance-based adjustment hasn't been fully designed yet, we really see that as a key vehicle for promoting quality, promoting health and outcomes. So just want to link this all back to what we're trying to get at through the program and our aims. Okay. So now we can go a little bit in a little bit more detail through each of the models and how payments will be structured in each of the models. Model 1 is pretty similar to the current state PCPlus program in terms of the payment components. We've, I think, talked about most of these, so I'll go quickly. But Model 1 includes the medical fee-for-service payments. That'll kind of stay status quo, a population-based payment that'll basically be constructed to approximate the cost of care delivery requirements in the model with HRSN risk adjustment. And then, of course, Model 1 practices will be eligible for performance-based adjustments. And again, this model is really available to practices that aren't as ready to take on the higher level APMs and take on that capitated payment for medical services we've been talking about. So for Model 2, again, the model for primary care practices that are not FQHCs or RHCs, the population-based payment and performance-based adjustment, those are pretty much the same structurally compared to Model 1. What's new here is the PMPM for medical services. So to provide a little bit more detail on what that will look like. So in Model 2, the PMPM will be standardized across providers. So there will be one PMPM rate that all participating providers will basically receive to cover the cost of primary care services, but then also behavioral health services delivered in a primary care setting. That rate will be based on historical fee-for-service claims, so claims reimbursement, so how much were practices reimbursed in the past for primary care and behavioral health services provided to Model 2 attributed members, and basically take that amount and convert it into a per member per month amount with some adjustments. Those adjustments being one, medical risks. So each practice would receive a practice-specific adjustment based on the risk of their patients. And then we would also apply kind of an average leakage adjustment, which we talked about previously, but just to say basically to reflect that members are moving around and not always going to their attributed practice, making sure that that is reflected in the calculation of that standardized PMPM rate. So that's a quick overview of, oh, go ahead.
Well, as one of these questions, I just want to raise up one of the questions in the chat just because it's pivotal to like the understanding of model 2. Could you say again, so the question is about whether the primary care practice would then be expected to address all of the patient's behavioral health needs, and meaning that would the patient who saw a counselor outside of the practice still be reimbursed separately? So I know it's an important distinction to make.
Yeah, so a practice, first of all, this would only be a small set of behavioral health kind of codes that would be included in this PMPM. So really the behavioral health services that the practice we're talking about provides to their patient would be included. More specialized behavioral health services would be outside of this. And so if a practice sees their attributed patient and provides a behavioral health service that's outside of this set of primary care behavioral health services, that would be paid fee for service. If a patient goes elsewhere to receive any of these services, that would be paid fee for service. And so the practice is not responsible for care provided by other providers or and receives fee for service for codes that aren't included in the PMPM. Does that answer the question? Are there other caveats you wanted to add, Olivia?
No, I think that answered that. We'll see if they put another thing in the chat. I will let you know.
Great. Okay. So that's model 2. I will take us to model 3, which again is for FQHCs and RHCs, and of course reflects the unique rules that govern FQHC and RHC payment, which are of course different from other providers, and also reflects the highly integrated care that many FQHCs are providing. So a key difference here with the medical PMPM compared to what we've talked about in Model 2 is that Model 3 will have a individualized PMPM calculated for each participating FQHC or RHC. That rate will be based on that FQHC's historical encounter reimbursement for attributed members for all services that are included in the encounter rate. So basically, the rate buildup will only include services provided to the specific FQHC's attributed patients and will only include the services that FQHC offers. So this is basically a broader PMPM because it's covering a broader set of services than just primary care. And it's pretty different from Model 2 in that, again, it has that flavor of being individualized to each FQHC. Because of that structure, this doesn't need to be adjusted for leakage or medical risk because the buildup already does that essentially by only looking at historical reimbursement for services provided to attributed patients at that FQHC. And then, of course, the population-based payment, the structure is largely the same. The performance-based payment will be part of the program. And then you get your total primary care payment. And of course, per federal rules, total payments will be reconciled at a minimum to PPS. So I just want to make sure that we're clear that we are aligning with federal requirements here too. Any questions coming up on Model 3, Olivia, before we keep going?
Not on Model 3, and I think just I'll plan to continue to answer some questions in the Q&A, and then some of them I think will be more effective to just go back to at the end of the presentation to not confuse everything in the middle of it.
All right. Well, then I will turn it back to you, Olivia, to talk about the RHTP alignment.
Great, thanks. So as has been mentioned, it's actually quite fortuitous timing that the Rural Health Transformation Program has a lot of alignment with what we've been talking about today at a very high level, and we'll put additional links in the chat. The Rural Health Transformation Program is a federally funded 5-year initiative to push out a lot of money to all states in support of transforming rural healthcare and supporting rural communities. And Maine's been having a lot of engagement with the public and different parties around our plan, which we submitted last fall, and is just now, 2026, been awarded and able to kind of move forward with what rural health transformation program spending looks like for Maine. We are going to put into the chat 2 webinars that will go into a great level of detail. I think that would be really important to listen to for this audience. One's tomorrow, one's next Tuesday. So for more information, you'll want to go to those events. But specifically to what we've been talking about today with primary care, broadly, there are many activities within the Rural Health Transformation Program plan for Maine that would support providers in being ready to transition to an alternative payment model, such as what we're talking about here for the future state of Primary Care Plus. Very concretely, Maine's plan now explicitly includes what is called an alternative payment model transition payment, or for providers, select providers, which is going to be based on the same kind of construct of an APM readiness assessment, and having providers articulate what sort of investment or funds would be needed, how would they spend the funds to make their organization more ready to transition to alternative payment models, not just Primary Care Plus, but also other alternative payment models that may be under consideration. So the APM readiness assessment that we talked about here, which would help us determine which practices have low levels of readiness and might be able to enter into model 1 of this future state. That's an opportunity to kind of link to a work plan or a glide path for getting to, well, what investments would move you to become more ready to take on additional levels of risk or move to the model 2 or model 3 in this example. So for year 1, when you hear more about the Rural Health Transformation funding, we're really talking about broad-based support for select providers, in which would include, at least some majority of primary care providers that at least provide some uncompensated care or have other criteria met to support this transition to alternative payment models. So money that will support you in getting ready. Also within Maine's Rural Health Transformation Plan, just separate from APM readiness, there is significant dollars associated with electronic health record upgrades, enhancements, and replacements. This was a broad area of interest from a lot of different provider groups regarding how to best use these federal dollars. And you'll hear more about that in these other webinars and how opportunities to access those funds. But of course, those kind of capabilities are really supportive of readiness to transition to APMs. And there's lots of other things that I'm not going to cover in this 2 minutes here within the Rural Health Transformation Plan that would support a practice in becoming more ready potentially to move to models 2 or 3, including thinking about how you leverage and work with CHWs, for example, community paramedicine. What workforce needs do you have? How do you recruit and retain the workforce you need to be effective in these models? How do you partner across settings, et cetera? So lots of opportunity in that sense, good timing for this influx of federal dollars, and that'll be a work in progress for the next 5 years.
All right. So just to wrap up, want to relift up the key elements of the future state of PCPlus that we've talked about today. So, refining and updating care delivery requirements, new policies around potential new policies around CHW integration into the program, adjustments to the attribution methodology, and then core to payment, really this transition to capitation in models 2 and 3, updating the population-based payment rate itself, but then also adjusting it based on health-related social needs. And then lastly, updating our performance-based adjustment methodology. So we've gone through a lot, and we really, again, appreciate everyone's sticking with us and appreciate all and any feedback from the group. And want to just say that in the coming years, we will continue to solicit and integrate feedback from today, but then also going forward as well, with a goal of finalizing a future state PCPlus design before shifting to developing a rate methodology and getting into rate setting before implementation. So that's where we're headed. And with that, I think we can turn to Q&A. Perhaps I'll leave up the summary slide as we do Q&A, if it helps prompt people.
Thank you so much, Emily and Avi. You did a really excellent job. So I want to, save 2 questions for us to talk through live. Going back to, I believe this question is about Model 2. If you want to go to the visual for that one, talking more about this idea that we're incorporating the cost of including an attribution and incorporating the cost of behavioral health integration services within the standard PMPM. So the question is really trying to understand how some practices currently are providing integrated behavioral health, and then other practices are not providing integrated behavioral health. And so thinking about is the rate setting or is the expectation in this model that we're going to be incorporating the cost of those behavioral health set of behavioral health services so that to make sure that they're still funded, I guess, because if you consider that some practices are not delivering these services, we don't want the rate to be, then not including the fact that those costs are lower then because they're not included. So if you want to speak to that in general, I know the actual rate setting is obviously a later stage, but just to clarify what the thought is here.
Yeah, so we haven't yet defined what the behavioral health services we're talking about are, but the hope here is to be selecting services that a large majority of participating practices are offering with the hope that we're promoting integration in terms of model participation. So the thinking here is that it would just be one rate and um, going forward, I think the hope is that participants in Model 2 would be offering the set of services that are included in the PMPM. Olivia, anything you want to add to that?
Right.
Or Avi,
I'm
go
also
ahead.
just happy to jump in. Excuse me for a second, and Olivia, you should too. I mean, the goal here certainly is actually to be ensuring that funding for behavioral health integration services is provided in a way that's much more flexible. So practices that are delivering these kinds of services are not as sort of, wedded to the fee-for-service construct and has more flexibility to be able to deliver the kind of care in the right setting. This is good feedback, and it's going to be important in thinking through, as the rate development phase, when that starts, really making sure that there aren't perverse incentives here. So it's helpful feedback. I don't think it's something that we can answer here, except to note that the objectives are, in no way to reduce funding here. It's actually to provide the funding in a more flexible way to ensure that practices can deliver the care that they want to deliver. So Olivia, you should weigh in. I know that that's not an entirely satisfying answer, but this is good and helpful feedback as we move, as the department moves into its next phase of work.
Yeah, no, I think that's right. I just want to say that so I think it's kind of like what we're saying too is that so there's going to be some expectation that there's some level of behavioral integration happening in Model 2 practices, whether how that's defined in the care delivery requirements, TBD, but that is part of why we also think it's fair to then incorporate the cost of those types of services in the PMPM. But to Avi's point, we know that practices are delivering behavioral integration in a variety of ways. It's not always adequately represented in fee-for-service, or it's represented differently across different practices in their fee-for-service billing and what MaineCare covers or doesn't cover. Thinking about, like, for example, like the collaborative care model or other screening services. So it's definitely a difficult one because historical fee-for-service claims are going to look different and than what we expect future kind of standardized rates to look like. So definitely good feedback for the next part of this. One more question on, let's see, I'm trying to think what slides you should go back to. So a participant asked that they were, say they're glad that OMS is recognizing the additional time and effort based on health-related social needs. I think HRSN or social risk adjustment being part of this. But thinking about will time with social workers be included in the non-billable hours when thinking about attribution? And this is the tricky question because I don't know where Christy's from, but it's kind of a different answer, I think, when you're thinking about FQHCs and what you talked about with Model 3 than necessarily some of how attribution might work in other settings. So I think if you could just generally speak to like attribution again and when non-billable services play into attribution or not.
Yeah, and I'll just say when we're thinking about non-billable services counting towards attribution, we're not, I think I use the CHW example. This wouldn't be necessarily limited to just CHWs, but these could be touch points by a number of different care providers with the patient. And just to say again, the thinking is that those kinds of touch points would be counted in determining should a patient continue to be attributed to the practice. Um, the over time, the question around with the cost of those services, the thinking is that the cost of the care delivery requirements separate from attribution are are going to be built into our determination of what the population-based payment should be. Um, but that is separate from the question about counting those services towards attribution. So I just want to make sure we're talking about those things distinctly.
Great. Yeah, and she was talking about model two. So again, like same answer as far as attribution and attempting to account for what you said, non-billable outreach in that way. But yeah, it gets a little bit different when you talk about the cost of the services and how different providers have costs incorporated into their capitated payments.
I'll also just add that because this is all about continuing existing attribution, our thinking is that this wouldn't start impacting attribution until the second year of the program so that we can build up the history before that. So this is also something that's a little bit further off in terms of actual implementation.
Yeah, Rachel, well, someone has asked a question, I won't call her name out, on about cost of living adjustments or the impact of inflation that exists in the world and it impacts cost. So I want to say something to start, but then I'd like to hand it over to Manat to talk about some of the ways that these rates we would think about these rates changing over time or being adjusted over time. But before we get into kind of how that would play out here, want to also say that that we would be intending to make appropriate adjustments over time to these rates, whether it be through a cost of living adjustment or other type of adjustment, which I'll turn it over to the Manat team to talk about, or what we consider rebasing timelines and other adjustments. We'll keep it at a high enough level for today, but and from a main care perspective, that's always been the goal, and that it's a kind of a partnership with the legislature to make sure that there are sufficient funds to do all of those adjustments each year. And it's definitely a goal of main care rates to stay appropriate over time, taking into account inflation. But if we want to talk about it in terms of the models, I'm to hand it over to you all.
Sure. So when we say here, and just to restate, I think what Olivia said, when we say the rate is going to be based on historical fee-for-service claims, that's really the basis, but going through the rate setting process, that will be, carried forward and, adjusted for changes over time. And so that this is all going to be probably much more complicated than is on this slide. This is a little simplified, but want to just make sure it's clear that we will be really careful about not underpaying here by just basing off historical dollars. I want to add, and Olivia referenced this too. So for FQHCs and RHCs, because the rates are kind of flexible in terms of being individualized by FQHC, they'll be also subject to some other changes. So they'll be based on the encounter rate. The encounter rate will also be going through a rebasing process, every some odd years get kind of recalculated. And that recalculation of the encounter rate will flow through to updated PMPM rates and PCPlus. So that's one way that they'll change over time. Additionally, again, because these rates are individualized to an FQHC and dependent on the services that they provide, scope of service changes will also impact these rates to the extent, an FQHC opens or starts offering a new service. We need to make sure that is factored into this in a fair way. So a few moving pieces here in terms of changing these over time.
Yeah, so I'll just add, I think what Emily and Olivia said both both is right. So like from a, a rate setting perspective, it's very common for there to be adjustments to account for changes in service acuity, changes in price, right? There as the participant noted, I mean, there have been really significant increases in inflation, right? So that there are standard ways where that would be taken into account in rate setting. And then, like Olivia said, a lot of this is also about, the department's partnership with the legislature in evaluating payment levels, but there are certainly ways to capture that in a rate setting process.
Yeah, I had some great conversation in the chat about interest, and we all want to see multi-payer alignment. We shared that one of our aims, and that there's a lot of conversation to have about that topic. So we agree, and we know that you need. I think studies show different values here, but you need a significant portion of dollars kind of running through the same payment model, and ideally with the same care delivery requirements in order to impact actual practice change. Which is we had a lot of conversation about this when we were drafting the project aims and thinking about what is our guiding principles. I'm sorry, when thinking about the aims and principles and how we know what main care can do, where we can lead, where we can do the work. And also know that we want to foster partnerships, support practice transformation, things that we don't have complete control over, but are absolutely hoping and will be kind of moving forward those conversations. And welcome you all to kind of to reach out separately if you have ideas for how you think that would go best with your own organizations or your own relationships. I think that's always like I think we need to come to the table together on that. But I appreciate those comments. We don't have any other open questions at this time, and we're almost out of time. Was there anything else that you've thought of that you wanted to highlight, Avi or Emily? Really, again, thank you so much. We wanted to both talk about high-level goals and also talk about some detail. We also very much consider this an update to you. This is as you saw, our current thinking. These are what we're considering, giving you kind of insight into that so that you can think about it some more, and we'll have additional avenues for you to provide additional feedback, more of these conversations. Like, these are not done deals in any way, but we wanted to demonstrate that we've been spending a lot of time on this and working through these tough questions and bring it to you all to be part of the process. So yeah, the best way to stay up to date on the official meetings such as this is to sign up for e-messages and check the box for primary care and care coordination updates. These materials are posted on the very comprehensive main care rate reform website. We have a log of the Q&A from today, and if there's anything we feel like might be additionally helpful to put in an additional document with Q&A, we may post that on that same website. I'm seeing some additional detailed questions come through that I'm not going to go to right this second, but we'll take those all in consideration for how we continue to provide more detail on this as we move forward. So you'll hear from us in a few different ways going forward. And then again, like recognizing that we do have still some time before we will get to the part of this where we talk about specific rates and fiscal impacts. But those are complicated conversations, and we'll look to you to engage in those so that we can hopefully all move in this direction. Thank you all so much for your time, and have a great rest of the day.
Thank you.
Thank you, everyone.